Thank you all for joining us today, both in person and virtually. We appreciate you taking the time to listen and learn so that we can help keep our patients safe. So let's see. Oh, there it goes. Okay. So today we're going to be talking about insulin administration, prioritizing patient safety. And I'm Dr. Megan Carell. I'm one of the pediatric endocrinologists here, and excited to discuss this stuff with you today. So my only disclosure is that this presentation was put together with the help of Dr. Thrasher, so I definitely can't take credit for all of the slides you're going to be seeing today, and I appreciate his help. And I don't have anything else to disclose. So our learning objectives today, we're going to identify common errors related to insulin use in hospitalized patients, provide an overview of ways to reduce errors, and then review policies at Norton Children's Hospital to reduce insulin errors. So while there is no definition of a medication error, the National Coordinating Council for Medication Error Reporting and Prevention defines a medication error as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. And so these events can be related to any part of the process from prescribing the medicine all the way to making the medicine and then giving the medicine to the patient. So an error can occur along any of those at any point in that pathway. So close to 6,800 prescription medications and countless over-the-counter drugs are available in the United States, and over 7 million patients are affected annually by medication errors. 7,000 to 9,000 people die in the US per year due to a medication error. Medication-associated error costs exceed $40 billion each year. They also cause psychological and physical pain and suffering. They decrease patient satisfaction and contribute to a growing lack of trust in the healthcare system. So very important for us to figure out how we can help prevent these from occurring. So this pie chart shows us, different types of drug errors that occur. So the largest percentage we have is omission of medication, so failure to give the medication. Next would be improper dosing, followed by an unauthorized drug. And then we get into the less common errors, so a prescription error, wrong timing or extra dose of medication, and then luckily, like wrong patient, things like that are a much smaller percentage of medication errors. So this figure shows the top 10 drugs associated with error warnings, and insulin is one of those top 10 drugs, which is one of the reasons we're focusing on it. And you can see some of the other medications as well that we would, are not surprised to see on this list. And then this is another list that shows the top 10 most common lethal medication errors. Insulin is number 2 on that list. So this is a study that showed that 2/5 of people taking insulin experienced one or more insulin error during a stay in the hospital. And this was between 2010 and 2019. So the chart breaks down based on type of diabetes and then whether, like for type 2, whether they're on insulin or not. And so you can see that our type 1 patients had a higher percentage of errors compared to our type 2 patients. But again, both type 1 and type 2 patients on insulin had a high percentage of them experienced errors. A good thing, though, to note is that the trend is going down in this set of data, which is encouraging that changes have been made and are being made to help prevent these from occurring. So there have also been a lot of insulin errors that are making headlines. So not only are we noticing it as healthcare providers, but also the community and the media are also noticing that these errors are occurring. So these are just some of the headlines that have been in the news over the last few years. Pennsylvania nurse accused of killing two patients, injuring another with insulin injections. 16 Indiana students hospitalized after getting shot with insulin by mistake. More than 260,000 diabetes inpatients had hospital medication errors in 2017. And insulin errors potentially plague hospitals treating diabetes patients. So definitely something that is being seen, throughout our country. So now we'll go through the types and causes of insulin errors. So the first type of error we'll discuss is omitted and delayed insulin. So this could be insulin not prescribed on hospital admission and transfer. So I feel like this is something we see sometimes here at Norton Children's Hospital, where a patient will be diagnosed with new onset diabetes in the ER. And then insulin is ordered, such as their long-acting insulin, and then their bed, happens to get ready faster than anticipated. They get moved to the floor before the Lantus arrives in the ER. And then sometimes that's overlooked and not caught that that patient never actually received their long-acting insulin. So making sure that when transfers occur, that what was supposed to happen in one place did occur, and if not, that we order the appropriate things. Prescribed insulin product is not available in the clinical area or following discharge. So different types of insulin may be available outpatient that are not available or on formulary inpatient. Confusion over insulin dose administration when patients are NPO. And then insulin not administered at an appropriate time to the administration of food, including enteral feeding. So that can cause trouble, depending, of course, there's lots of different factors in this, when food's delivered, if a nurse is in another room, taking care of a patient who's really sick, etc. So before we go to the next category of insulin errors, I wanted to talk about the different types of insulin because that can help you understand, how certain errors could potentially occur. So there are a wide range of types of insulin, anywhere from rapid acting to long acting insulin. Back in the past, we mainly used intermediate acting insulin and short acting insulin, but now we have much faster insulin. So we traditionally use rapid acting insulin and long acting insulin in our patients. So basal insulin refers to insulin that works slowly and lasts longer and provides kind of a background insulin and background action to help blood glucose levels stay in their target range when people are not eating and especially overnight. So these are your Lantus or your Basaglar. In our hospital, we use Lantus. That's what we have on formulary. And then you have your bolus insulin, which is your rapid acting insulin. These insulins work quickly and have a shorter duration compared to other insulins. And so we use these to control blood glucose levels at meal times. If you're on an insulin pump, we use short-acting insulin only in that pump. And so that pump will give small amounts of insulin throughout the day, which acts as your basal or your background insulin. And then it can also give boluses for meals and high blood sugars. So this chart shows, again, the different types of insulin, their onset of action, peak, and duration of action. So there can be errors with selection of the incorrect insulin product. For example, Lantus versus Linty. So Linty is actually not an insulin we use in humans anymore. It's used in cats and dogs to treat diabetes, but it was used in humans at one point. And its onset of action is about 1 to 2 hours, whereas Lantus, doesn't really have a peak action. And so as you could imagine, that could cause trouble. Humalog versus Humulin. So these, again, they look very similar, especially if you're trying to get insulin ordered quickly. Humalog is a rapid acting insulin. whereas Humulin is an intermediate acting insulin. Again, that could cause trouble with our blood sugars. The next one I think is probably one important one to highlight. So glucosine versus glargine. So glucosine is Apidra, that's its brand name, and it's a rapid acting insulin, whereas glargine is Lantus, and that's a long acting insulin. So certainly, if you mix up short acting insulin with a long acting insulin, that could definitely cause a lot of trouble. And then the last one, Humalog versus Humalog mix. So Humalog mix is a pre-mixed insulin that combines rapid acting insulin Lispro with an intermediate acting insulin Lispro protamine. And so its duration of action is about 22 hours. It's not something we use in pediatrics anymore. But again, if it is an option, you could see that would be easy, error to make because it is, pretty similar in name. So just being aware when we're ordering insulin, double checking this is the type of insulin I want. And then, of course, there's other parts to the process of giving insulin where we can find errors. So improper patient monitoring. So there can be a lack of prospective risk assessment to identify patients at risk for hypoglycemia. So it's important to establish and maintain clinically appropriate glycemic targets in both the inpatient and outpatient settings. This can be difficult because as we achieve tighter glycemic control, it can increase your risk for hypoglycemia, especially when situations change, such as going inpatient. Poor coordination of blood glucose testing with insulin administration at meal times. So, coordinating glucose monitoring, meal delivery, and insulin administration within the ideal time frame for rapid acting insulin is a significant challenge, especially in inpatient setting, like we mentioned earlier. So, two studies showed that less than half of patients met the goal of receiving a rapid acting insulin within 10 to 15 minutes of a meal, and 35% received glucose monitoring within 1 hour prior to insulin administration. So ideally, your blood sugar is checked within 30 minutes of that dose that's going to be given. And so, as we know, sometimes patients eat before they tell the nurse to check their blood sugar, before the nurse knows the food's been delivered. So there can be lots of areas in here where we can find some errors. Wrong route, so IM versus sub-Q. And then poor communication during patient transfer. Again, communication is key amongst all of the members of the care team. There can be no standardized process for alerting physicians, pharmacists, and nurses as to when insulin doses must be adjusted, held, or discontinued based on changes in the patient's carbohydrate intake. So, like if a patient needs to be NPO, if their G-tube feeds have been changed, things like that. So, making sure we have that protocol in place. And then, let's see, okay. All right, so there are risks associated with insulin use that we also need to be aware of, and I think you all probably are aware of most of these. So, of course, if we're giving insulin to lower blood sugars, we can cause hypoglycemia. So that could lead to seizures, coma, and death. So very important for us to be aware of what hypoglycemia looks like and how to treat it. Hyperglycemia, on the other hand, can also cause trouble. So that could lead to DKA, diabetic ketoacidosis. 33% of medical errors that cause death within 48 hours of the error are linked to insulin errors. So that's a pretty high amount of errors that ultimately cause death. In the inpatient setting, severe hypoglycemia and hyperglycemia are deemed hospital-acquired conditions by the Centers for Medicare and Medicaid Services. So CMS notes these events can be reasonably prevented, and so they will deny payment for DKA, hypoglycemic coma, and other serious conditions related to poor glycemic control if it occurs while hospitalized. So, for example, if we have a patient that has diabetes They're admitted to the floor because they're not in DKA, and then they end up going into DKA while on the floor and have to be transferred to the PICU. That would fall into this category of this is a hospital acquired condition, and so may not get covered by Medicare and Medicaid. So, wanted to go over diabetic ketoacidosis so that we can understand, errors that could occur potentially with DKA, with treating DKA, and other things along those lines. So, the quick and dirty definition of diabetic ketoacidosis. So, you have hyperglycemia, usually a blood glucose level of 200 or higher. You have acidosis, so usually a bicarb of less than 16 and or pH of less than 7.3, and you have to have the presence of ketones, usually moderate to large ketones. DKA is associated with high glucoses, but high glucoses alone are not causative of DKA. You can also have hemoconcentration. You can have hyperosmolarity. You can have a high white blood cell count, so you get a left shift with an increase in neutrophils. It can be associated with infections. And it's important to note that a third of new onset patients will present in DKA. And it is also more common among younger children than older children. Another thing to note is that patients may have lower blood sugars when they present to the ER, but still be in DKA. And this occurs if like they've been sick at home, they've given themselves a big dose of short-acting insulin and then come into the ER. So they've tried to treat it at home, but were unable to. So you may see that. So just because a patient's blood sugar is normal doesn't mean that they are not necessarily in DKA. So I really like this chart because it's colorful and I think it really breaks down the different parts of DKA that we, especially as endocrinologists, think about. So the things that can cause DKA, so stress, infection, illness, things like that, they make the body more resistant to insulin. And then, of course, for our patients that already have the diagnosis of diabetes, insulin noncompliance is something we think about. The core of it is that they are not getting enough insulin. There's not enough insulin to for the body to use glucose. Without insulin, glucose can't get into the cells, and so the body starts looking for other sources of energy. It breaks down fat and muscle, and in that process, that's where we get ketones. Ketones lead to our metabolic acidosis, and it's really the ketones that make our patients very sick. So it leads to the symptoms of DKA that we think about. So nausea, vomiting. It can lead to Kussmaul respirations where they're breathing really fast, trying to get rid of that acid. They'll have polyuria, polydipsia, and they can also develop altered mental status. The other thing, of course, we see is hyperglycemia. And the hyperglycemia also contributes to the polyuria. And these children, when they come in, they're very dehydrated. So, as you can imagine, we need IV fluids to help with the dehydration. And then we need our insulin to help with our hyperglycemia and to help clear our ketones. With DKA, you are at risk for cerebral edema due to fluid shifts, and your risk is higher if you come in with a lower pH and if you're more severely dehydrated when you present. Another thing to remember is that insulin shifts potassium into our cells, and so most of these kids are going to need potassium replacement, even if their potassium's normal when they first arrive. So our treatment for DKA is IV fluids and insulin. That's the core of our treatment. So with our IV fluids, we want to calculate our fluid deficit with a goal to replace over 48 hours. We use our 2-bag method. You may hear us talk about that. So we combine 2 bags of fluids, one with D10 and one without any glucose. And that way we can titrate the ratio based on what our blood sugars are doing and how fast they're coming down. We also want to consider when picking our fluids, do we want normal saline or half normal saline? And when we consider this, we want to look at our corrected sodium. So at high glucose levels, sodium is lowered secondary to fluid shifts. And so we need to calculate what our corrected sodium is. To do this, we use this formula. We take our serum glucose minus 100, multiply that by 0.016, and then add that to our measured sodium. And then, as mentioned before, we want to replace our potassium if needed. And honestly, I think almost every kid that comes in DKA needs potassium-containing fluids. Phosphorus can also drop with treatment of DKA. So a lot of times you'll see us use potassium phosphate instead of potassium chloride. And that also helps prevent the hyperchloremic metabolic acidosis that sometimes we see in these kids as their diabetic ketoacidosis is resolving. Sometimes they have a hyperchloremic metabolic acidosis due to all the fluids. So the potassium phosphate can help prevent that. We want to be careful that we don't replace fluid too quickly because if you decrease your sodium too fast or your blood sugar too fast, you can lead to cerebral edema. Typically, our goal is to lower our glucose by about 50 to 100 per hour. Sometimes if you give a bolus, your blood sugar is going to come down initially a little faster than that. So it just keeping a close eye on that. And then, of course, we're going to need insulin to fix this. So we start an insulin drip, not IV or sub-Q bolus. A lot of times you may get kids who outside hospitals have given IV insulin, like IV insulin bolus, and that is in our system and out of our system very quickly. So it doesn't really do much. When traditionally, when a patient's bicarb is 16 or higher times 2, and they're awake, alert, going to eat for us, and don't have abdominal symptoms, then they're ready to transition. Although if we have a patient that's just been diagnosed with diabetes, or if they're a little kid, we'll use a bicarb of 18 or higher times 2. So that we can make sure, especially with those little kids, they can be really tricky when you're transitioning them because they'll be like, yes, I'm going to eat all of this. I'm really hungry. And then you bring the shot in and they decide they don't want to eat. So we have to be very careful with those kids when transitioning them. When we transition someone from insulin drip to subcutaneous insulin, we give them their long-acting insulin or we restart their insulin pump if they have one. And then we let them eat and then we give them the short-acting insulin for their carbs, whether that's as a shot or as a bolus in their insulin pump. And then we turn off the insulin drip 2 hours after they get their long-acting insulin or after they start their pump. And that's because we want, especially when we give Lantus, we want to give Lantus time to reach its peak effect, which takes about 2 hours. So that's why we have that transition period. All right, so getting back to some more of our insulin errors and how we can reduce these errors. So when prescribing insulin, of course, you can consult your friendly endocrinologists. We are happy to help with doses and orders. It's important to document the indication for insulin use. So why is my patient on insulin? What type of diabetes do they have? And then, documenting what are my patient's doses of insulin. Especially if you're a primary care team, making sure you know what doses of insulin your patient is supposed to be on versus maybe what they're telling you they're doing at home, things like that. And then we can reduce insulin errors by developing and utilizing insulin order sets for the following. So transitioning from IV to sub-Q insulin, calculating and communication of insulin doses, having defined laboratory testing and other clinical monitoring practices, identification, communication, and management of critical blood glucose values, and then management of hypoglycemia. So having standardized order sets and protocols developed using evidence-based guidelines can optimize the treatment of inpatient hyperglycemia. Suboptimal care results when providers are inconsistent in their management of hyperglycemia. So this can occur due to the complexity of these patients, the complexity of euglycemia management in an inpatient setting. And so protocols and order sets, when they're designed intuitively, they can enhance efficiency of workflow and prevent medication errors by reducing variability. So, if everyone does the same process, we're more likely to see things happen the way they're supposed to, less likely that something will get overlooked. An order set should contain appropriate glucose monitoring, glycemic targets, and instructions for how to treat episodes of hypoglycemia or how to manage insulin therapy when a patient's nutritional status changes. So, this doesn't just apply to our medication orders, but also to our nursing orders and things like that. Explaining these are the steps that should happen when XYZ occurs. Other ways we can reduce insulin errors. So, creating policies to guide the care of patients with insulin pumps and continuous glucose monitors. So, these are our newest technology. Continuous glucose monitors are devices patients wear that measure their blood sugar every 5 minutes. And then insulin pumps give insulin throughout the day. So, it's something a patient wears. They change it about every 3 days. So, it's important for us to have policies so that patients can continue to use their technology when in the hospital. Ensure that insulin orders are free of error-prone abbreviations and dose expressions. The big U that a lot of us use sometimes when we're quickly writing what a patient's insulin doses are is actually not an accepted abbreviation. So important to write out units when we're talking about insulin in our notes and things like that. Just small things like that we don't necessarily always think about. And then communicating the insulin plan with all team members. Again, closed loop communication, extremely important, especially when dealing with a medication such as insulin. And then our pharmacy team is also important in helping us reduce errors. So creating a process to differentiate different types of insulin products. So, differentiating between rapid acting and long acting insulin. In addition, there are 4 different concentrations of insulin on the market. So traditionally we use U100 insulin. And so what that means is for every 1 ml, there's 100 units of insulin. However, there's also U200, U300, and U500 insulin. Sometimes we do use U200 insulin in pediatrics in patients who are getting like a lot of insulin per day, but that's few and far between. But again, as you can imagine, U100 versus U500 insulin, extremely different. In fact, there are many places that recommend that U500 insulin be stored completely separate from all other types of insulin, just kept in the pharmacy, so that those errors do not occur. Pharmacists confirm the indication before verifying insulin orders. And then, of course, double checking the orders and making sure they make sense. Insulin pens and vials are dispensed to the clinical units with a patient-specific barcode label. So this is important to help minimize, insulin getting mixed up between patients. And then auxiliary warning labels can be useful to differentiate products. And barcode technology can also assist pharmacy personnel in drug selection and validation. So, each different type of insulin has their own barcode, their own identification. And then ways we can reduce errors when giving and monitoring insulin. So again, having patient-specific pens that are stored on the clinical units that prevent inadvertent use on more than one patient. Using a coordinated process to ensure timely blood glucose checks and administration of mealtime insulin in conjunction with meal delivery. Document all point-of-care blood glucose values so that everyone on the team knows what's going on. And then at the time of administration of insulin, we should assess the patient's most current blood glucose value, assess the patient for symptoms of hypoglycemia. So just because their blood sugar 20 minutes ago was normal doesn't mean now they haven't developed signs of hypoglycemia. So, are they showing symptoms? Do we need to recheck a blood sugar before we give this insulin? Inform the patient of their most current blood glucose level and then inform the patient of their insulin dose and the full name of the product. Because not only are you hearing it out loud, the patient who, most of the time deals with this every day is hearing the insulin, hearing the dose, and they'd be like, hey, that dose sounds like way more insulin than I ever get. And so, of course, then we're all going to reassess, is this the correct dose for this patient? Safe transitions of care are also really important to reduce error. So having a coordinated process in place to identify patients prescribed insulin, and then patients discharged on insulin are assessed for understanding of their self-management. And I would argue patients, and in our situation, families as well, should be assessed for these things. So they should be able to demonstrate proper use, proper measurement, and self-administration of the device that they'll be using at home. So traditionally, most patients use insulin pens, but there are situations where we use vials and syringes. So just making sure they know what they're going to be going home with and know how to do it. Making sure they know how to monitor their blood glucose values at home. The signs and symptoms of hyperglycemia and hypoglycemia, and what they should do if they notice these symptoms. They should understand common types of errors that are possible with their insulin therapy, such as, this is your long-acting insulin, this is your short-acting insulin. Usually, like with pens, they're usually different colors. So, helping families understand that, and then helping them know how to prevent or detect these errors. And then just making sure they understand the importance of regular follow-up, both with their primary care provider and their specialist, including the date of their next appointment. All right, so now we're going to go through our order sets that we have here at Norton Children's to help minimize insulin orders. So first, in general, we have our general orders where, what blood sugar should a house officer be notified about, both low and high blood sugars. And then following that, we have our urine ketone treatment instructions. So nursing orders, when should we check for ketones? So for most patients, it's if they're sick or if their blood sugar is above 200, we want to check for urine ketones. It also has instructions on what to do if a patient is eating versus not eating in regards to insulin orders and urine ketone checks. And then we have up at the top, you'll see orders on how to transition a patient from IV insulin, the IV insulin drip, to subcutaneous insulin. And then we also have the symptoms of hypoglycemia to look out for. So these symptoms can be anywhere from hunger, nausea, just not feeling right, feeling dizzy, all the way to confusion, seizures, loss of consciousness. Um, Next, we have our hypoglycemia treatment protocol. So we have when to check blood sugars, and then our hypoglycemia protocol is, activated should be activated if the patient's blood sugar is less than 70. And then it goes through the steps that we would take. So we give them 15 grams of a simple carbohydrate. So that's orange juice, glucose tablets, something that's going to make their blood sugar go up quickly. Then we recheck their blood glucose in 15 minutes. If it's less than 70, you're going to give them another 15 grams. If it's above 70, then we're going to give them some complex carbs with some protein. So like peanut butter crackers, something along, cheese, something along those lines. And the complex carbs helps keep their blood sugar from dropping again. So this is the order set that we would use for someone who can eat. And then, oh, there we go. All right. So then we also have a protocol for someone who is alert, but it is for whatever reason NPO. And so if they can't eat, we can use dextrose containing IV fluids. So we still follow the rule of, rechecking in 15 minutes to see if that blood sugar is going up the way we want. And then if a patient is unconscious, having a seizure, something along those lines, that's when your glucagon comes into play, and that's when we would give that glucagon. Of course, another part in each of these um, protocols is to notify the house officer so that they can also help examine the patient and see if any changes need to be made to their current treatment plan. Next in the order set, we have our labs. So the things that are like pre-checked for you when you pull this up is blood glucose monitoring and point of care urine ketone checks. If a patient is taking regular PO, then we do blood sugar checks before meals, at bedtime, and then at 3 a.m. If they're in PO, or if they're on dextrose fluids, usually we want blood sugar checks every 4 hours. And then urine ketone checks, as we previously discussed. Usually, when they're in the hospital, we check them with every void so that we can trend them. And then we have RFPs. This is a tricky one, I will say, because sometimes patients don't need repeat renal function panels. If they're not in DKA and the ER, we don't necessarily have to recheck. So it is automatically checked for you, but definitely something to stop and think, do we really need to be checking more labs on these patients, or can we forego that? We want to check an A1C on everyone that comes into the hospital. So sometimes it's already obtained in the ER for you. So if not, you can get that. And then we have our new onset labs here to check if a patient is newly diagnosed with diabetes. A lot of times the ER has already obtained these labs, but sometimes we get someone who's come from an outside hospital and they were stabilizing the patient and didn't have a chance to grab new onset labs. So those are all here for you to order. So we have our pancreatic antibodies, we have our celiac panel, thyroid labs, thyroid antibodies, and then a C-peptide as well. So for every patient with type 1 diabetes, because it's an autoimmune condition, they're at risk for other autoimmune conditions, which is why we screen every patient with new onset type 1 diabetes for celiac and for thyroid conditions, because those are the two autoimmune conditions they're most likely to have. And so we check that. And then every order set automatically has an inpatient consult to pediatric endocrinology. Any patient that's on insulin should get this order, and you can't sign the order set without this being added or checked. Next, we have medications. So we have our fluid options. So sometimes we use dextrose fluids in our patients with diabetes. So it's important to talk with, your endocrine team to see, is this someone we would use them on? So traditionally, we don't use dextrose fluids, right, in someone with diabetes. But if a patient has ketones and their blood sugar is less than 200, then we cannot really treat them with insulin to get rid of those ketones. So sometimes that's when we'll add sugar to the fluids so we can get their blood sugar up so that we can safely give them insulin to clear those ketones. So that's the situation we would do that in. Next, we have our orders for our hypoglycemia treatment. So we have our glucose tabs, our glucagon, both IV and IM. And then another thing I wanted to highlight was our diet order. So nothing is clicked for you automatically, but this is the one we want for our patients with diabetes. So we want the consistent carb, no juice. And then, like, if patients have a renal diet or low salt diet, sodium diet or something, you can add that in the comments. But this order will make sure that your patient gets no juice and then a carb count, like a carb breakdown with their meal. So that can be very helpful. Next, we have the insulin. So traditionally, our patients are on the multiple daily injection plan. There also is a basic insulin injection plan. We do not use this in pediatrics, but just wanted to make sure you all knew what these other options were, because certainly when we're talking about error, we could, accidentally order one of these other types of insulin. So for our pediatric patients, we use basal insulin, usually Lantus. is what we use. Sometimes our patients are on Tresiba. Levemir is no longer made, so that's not on the order set anymore. I forgot to black that out, but that's not an option anymore. And then in our hospital, we have Humalog. So that's what we use for our short-acting insulin here. Oh, yeah. So that's the order area that you want to be in. All right, so then once you pick your short-acting insulin, this is the fun list of things you're going to get to fill out. And there's a lot of different parts to this, which can be very daunting. So we will go through each of these parts so that you can, understand what we're looking for and kind of how we get those numbers. So we will start with our blood glucose target. So this is the blood glucose level that we are trying to get the patient's glucose to. So this is what we're aiming for. This target can differ by age. So younger children usually have a higher blood glucose target. Usually it's 150. And then our older children will have a lower target, usually 120. Our blood glucose threshold is the blood glucose value at which we start to give corrections. So usually this is the same as your glucose target. So you can usually assume that it's the same unless you are told otherwise. There are special circumstances when we set this higher to prevent hypoglycemia. Usually, this is in our kids that don't have type 1 diabetes. So, this will be like, for example, a kiddo with cancer who is getting hyperglycemia secondary to their steroids. Sometimes we'll say we're not going to give them insulin unless their blood sugar is above 150. So situations like that is traditionally when their threshold will be different. Our correction factor, so this is how many points will the blood glucose come down with 1 unit of insulin. So for instance, if a patient's correction factor is 30, we expect that their blood sugar will come down by 30 points for every 1 unit of insulin we give them. So how do we use this correction factor? So we take our current blood sugar, subtract our target blood sugar, and then divide by our correction factor, and that will tell us how many units they should give for their high blood sugar. Then we have our insulin to carb ratio. So this is how many grams of carbohydrates are covered by 1 unit of insulin. So, for instance, if someone's carb ratio is 10, for every 10 grams of carbs they eat, they should get 1 unit of insulin. So we add up the number of carbs they eat, we divide by their carb ratio, and then that tells us how many units of short-acting insulin they should get for that meal. Then we also have ketone corrections. So ketones require extra insulin for treatment because they increase insulin resistance. And so in order to figure out how much you should give for ketones, we calculate it using a percent of their basal insulin dose. So for small ketones, we use 10% of basal insulin. For moderate ketones, we use 15% of the basal insulin. And then for large ketones, we use 20% of basal insulin. A lot of times, this is something you won't have to calculate. It's something we calculate at every office visit. So it should be in the notes as well. But that's where we that's where we get those numbers from. All right, so we'll go through a few examples. So your patient has a blood sugar of 225. They're going to eat 60 grams of carbs. They don't have any urine ketones right now. Their insulin to carb ratio is 1 unit for every 10 grams of carbs. Their correction factor is 1 unit for every 35. And their blood sugar target is 120. So first we'll calculate how much to give for their carbs. So they ate 60 grams of carbs. We're going to divide by 10, which is their carb ratio. So they get 6 units for their carbs. Next, for their correction, their blood sugar is 225. We'll subtract their target blood sugar, which is 120, and then divide by 35, which is their correction factor. And that'll give us 3 units of short-acting insulin just for the high blood sugar. Then we add these two together. So total at this time, they'll get 9 units of short-acting insulin. All right, so let's say our patient's not going to eat. Their blood sugar is 425, and they have small ketones. We have the same doses of insulin. So for our high blood sugar, we're going to take 425 minus our target of 120, divided by our correction factor of 35. We'll get 8.7 units. So we'll round that up to 9 units. And then for our ketone correction, we take our basal insulin, which is 30 units a day, multiply that by 10%, and we get 3 units for our small ketones. Then we'll add these together, and so the patient will get 12 units of short-acting insulin at this time. All right, so we also have a separate order set for patients on insulin pumps. Most of the core orders are the same. So when to notify house officers, urine ketone treatments. The biggest changes are that um, we have nursing orders in here to observe patients when they place new insulin pumps, and then to look at the insulin site um, at least daily for signs of infection, inflammation, pump site failures, things along those lines. And then we also have an order regarding giving meals through the pump. So the patient and the family may operate the insulin pump to provide meal and/or correction boluses, but all doses must be confirmed by the nurse and prior to being given and must be documented as well. I believe that's the only difference in these. And then we have our hypoglycemia protocol, is the same treatment, our same labs, although of note, the new onset labs are not in this order set because there's not going to be a patient that's on insulin pump that hasn't already had that workup. So and then we have our consult to endocrinology. Our fluid orders are the same. Our hypoglycemia treatment orders are the same. And then we get to the biggest change, of course, which is the insulin pump order, which is also very daunting. So it has many different rows. And the reason this is because patients can have many different settings for different times of the day. So they get different carb ratios, different correction factors. And that's one of the great things about the pump is that we can be more detailed and more specific with dosing with the pump. This, I think, simplifies it a little bit. It's less words, but the same thing. So at the top, we have your carbohydrate ratios. So the biggest difference is that you're going to have to specify what hour the orders are for. Same with the correction factors. So you give 1 unit of Humalog for each blank. So that's the correction factor. So 35 of a blood glucose greater than the target blood glucose of 120. And then you put the hours. And then we have our basal rates. So patients on pumps do not have long-acting insulin. Instead, they have basal rates. So this is how many units they're getting per hour. And so a lot of times patients will have several different basal rate settings. So that's where you put those in. And then if they only have one, you just delete all the other rows. You only need one row. The next thing it'll ask, and the basal insulin rate is if we're changing how much of their basal insulin they're getting. So, are we going up by 10% or down by 10%? So usually you just say we're continuing the home regimen. That's an option. And then next is our ketone plan. This has a plan if they're eating versus not eating. Traditionally, this is going to be the same doses whether they're eating or not eating. One trick to find insulin pump orders, if you do dot insulin, there is a dot phrase where you can pull in the insulin pump orders. And that's something we update at each of their office visits. And so that could be a good place to start when you're looking to see what are these doses. A lot of times patients too know how to help you find what the setting, where the settings are in their pump, if we're not around to help. So a lot of times they are really good at driving their pumps and are faster than us sometimes about finding those things. So, and then of course, we're always happy to help because we know this is very daunting. Double check things and make sure things look good. I think one of the things to remember with the insulin pump order is that this is not going to affect what their pump is doing, right? So this is really for us to document, especially for nursing to be able to document. And so, of course, we want it to be as accurate as possible. But just know that like it's not going to change what their pump is actually doing for them. And then just another word about automated insulin pumps because we are seeing more and more of our patients with this technology. So, what this means is a patient has a continuous glucose monitor, measures their blood sugar every 5 minutes, and then they have an insulin pump, and the pump can communicate with the Dexcom or the Libre. Those are different brands of continuous glucose monitors. And it can make changes to the insulin doses based on what the blood sugars are doing and based on the trends in the blood sugars. So, if the blood sugars are starting to go down, it can decrease that insulin in the background. If it's rising, it can increase it. And so it's important to know that when you go to give a patient a bolus for their meals or for a high blood sugar, the amount of insulin the pump is recommending may be different than what you would calculate based on their correction or carb ratios. And this is because the pump is taking into account how much insulin is on board. So, how much insulin is working in that person's body based on how much it's been giving them over the last few hours. So at the end of the day, we're going to give what the pump recommends. And then just document what the pump told us to give. If there's a huge discrepancy, then, we can look to see is something else going on. But usually it's not a big difference, but the pump and that algorithm is taking into account a lot of other factors that we can't necessarily account for. So do what the pump says. That's the big thing. And then other policies we have here to help reduce errors. So our insulin pens are labeled with barcodes that are patient specific. We use two-person verification for insulin administration. So you'll see our nurses always have a buddy with them when they're giving insulin to verify patient, type of insulin, insulin dose, etc. We have policies in place to guide the care of patients with insulin pumps and continuous glucose monitors. So with continuous glucose monitors, we cannot use these blood sugars to dose shots on when patients are on MDI. We still have to do finger checks when they're in the hospital. So that's currently our policy. And we're very upfront with patients about that. But they can still wear their CGM in the hospital. And we want them to because it's helpful. And then we have our pharmacists who review our orders and confirm everything. And then we have our inpatient diabetes educators and our endocrinologists available to help. And our educators, make sure that our patients and families learn everything they need to be safe and take care of their diabetes at home. All right. That's all I have. Any questions?
There's a situation where a patient comes with the pump, we take it off so we can manage the insulin, and then we send them home, but I don't know, if there could be like an issue with the insurance or something like that, and they cannot get a new pump. So we send them with like the pens and the insulin and all that.
Yeah. Yeah. So the question was, is there a situation when a patient comes in on an insulin pump, but maybe there's a problem and they don't leave on the insulin pump? Absolutely. We have definitely seen that situation. So if a pump breaks, each pump company has like a helpline that families call. Usually they will overnight things, but there are situations where that may take longer, such as a holiday weekend, which is when pumps like to break. And so we'll do shots at that time. Also, sometimes patients for safety reasons have to come off the insulin pump. So if a patient uses a pump to overdose on insulin or things like that, we'll take them off of their pump and put them back on shots. So yes, that definitely happens. And then occasionally patients will say, I don't want the pump anymore. I want to go back to shots. So we do it then too. Yeah. And we always ensure that patients have a way to give shots at home, even if they're on a pump, because like I mentioned before, pumps like to break at the worst times. And so they should always have um, some way to give long-acting insulin at home and then some way to give short-acting insulin at home, even if they're on a pump. So, good question. All right, these are our references. And then this is the QR code today to scan to get CME credit.